Welcome to National Innovation Center. So is Dr. Damodar Pavel is here? Did he
No, he's yet to join. He didn't came.
Okay. So I hope you are enjoying your trip to Nepal.
We are.
Sorry, I miss you there. Because I'm still traveling. I don't know when my travel will end, but looks like my travel will end on June 6th. That's my date of arrival in Nepal from UK. So I'm just traveling and visiting different places and meeting people and having interaction program about the necessity of the research and innovation for the economic development of Nepal. So that's what I have been, talking about for 2 months uh, in 16 countries. So far, I visited 16 countries and get more than 75 lectures like this. And so I'm just about getting tired, but not so tired yet.
That way, Dr. Pune has already welcomed you from other side of the world, across the globe. I guess I don't really need to tell you about what NIC is doing for Nepal's economic prosperity. We are really thankful to Unimate, Neomate, I'm sorry, because I was trying to catch the word, but Neomate. I've been serving the board last 4 or 5 years by now. And when the pool is off for travel or duty work, mostly I tend to more time here. My background is basically finance and ecosystems. I would like to thank Dr. Varda and Dr. Brandon, Dr. Allison, and Dr. Shiva, and Dr. Suchita, Dr. Susanna, and thank you so much. And basically, Sanjay actually, this is a very long journey. This is the Kapoor's dream. We call it a brain child. And we have many heads trying and support his dream. Actually, as you see, a lot of countries are facing and going to face economic crisis. A lot of announcements already made in many countries in Europe and in Asia, starting with Sri Lanka. And yesterday I had one TV show. What is going to happen soon in Nepal about food security and economic crisis. The foundational idea of establishing this innovation center is to make Nepal slowly but surely economically prosperous and independent. This is a very, very long journey. Maybe when we reach the objective, maybe we'll be there or not. But it's like building block or putting one brick after another. And we really welcome you not only today. You are already on the board because you have already contributed a lot. New made. I have been following how the collaboration and partnership is working with New Made and NIC. And coincidentally, Dr. Poon really doesn't want to ask for financial help. We are not sending any proposal anywhere seeking for financial help. every help that's coming, support or contribution is coming out of own will and so moto participation. And we have never really formally sent any proposal to any corporations or any donors or whatever we call it. This is only a friendly gesture. People are swinging and coming and participating. He always advocates for three kinds of supports. First, ideas. Second, time. And the least, not last, other way around, is money. Definitely, we need resources. That is coming in different forms. And this regarding this, what you call this Nyano Nani, you call it, yeah. When I am very new to, not only new to, I know almost nothing about innovations, but in the team we need all different heads. That's why I'm trying to compliment a little bit. I know like some innovations are inventions, which happens once in its lifetime, and another are something like kind of innovation, and sometimes we see a lot of imitations also. I don't know what exactly we are doing here, maybe you know it better. And saying all that, what I mean to send as a message or put up matter is like Nepal needs affordable technologies. Regarding this, value also, I know a little bit of finance and public finance and how the prices are fixed, how the market is controlled and how the free market works and all that. All this product has really helped a lot of institutions, health centers, I guess you know it better. Where they couldn't afford to buy from the market, they are able to buy from us, take from us. And I would like to refer to one little pleasant and comfortable incident that happened to us regarding this Nyano Nani is one of the banks, B-class bank, we have 4 class of banks before. They came up with their proposal saying that we want to participate in this movement. Then they have become a sponsor to manufacture Nyano Nani, and that is Duty Because Bank. At this moment, in front of all these good hearts and souls, I would like to thank them. That's the first probably corporate partnership in our history. I'm taking it as a milestone. Maybe in the days to come, we'll have so many of corporations because since the government, we just had our policy and programs announced by the President of Nepal, and they are also very hardly anything about innovation. And when we'll have tomorrow, going to have a budget coming out for the next fiscal year, and we should hope, but probably there will be very least amount allocated for innovations. All we can do is take support from individuals and corporations. Maybe in the days to come, with your technical supports and your good gesture and supports, and the corporation and individual financial supports will be able to manufacture, produce, or modify some of other biomedical equipments to help needy people, needy institutions perform their job better. So with this, I would like to thank you very much, and I will welcome all of you, and thank you very much from the side of the United States.
So much, Hari sir. Now we'll start with the program now. So Dr. Bernard Fassel, he is going to moderate our program. So I would like to hand over the program to Dr. Bernard.
Thank you so much. I would love to start really with introductions, and I think the best introduction is going to be coming from Dr. Poon, because I think he is the mastermind of this project. And as he has approached, Dr. Poon, could you give a brief overview of the path that you have taken with the infant warmer, and then I would like to go around with the table, then everybody introduce themselves for a minute.
Can you use mic, sir? Maybe you couldn't hear.
Oh, It's like, Mahavir, could you hear me?
Don, is it Don?
Mahavir, could you hear me? Maybe he has bad connection. You know, until he gets back, let's just go around.
Yeah, please, yeah, I think that's good.
I'm Dr. Sita Joshi and I look after the new contact care unit. Hello everyone, it's good to meet you today.
Hello.
I'm Dr. Smriti Mathura. I'm working as an associate professor in Kathmandu Medical College. We have a 40-bedded NICU in our institution, and I'm also involved with the Nepal Pediatric Society.
Good afternoon, everyone. I'm Dr. Pradeep Gupta. I'm working as a assistant professor in teaching hospital, Maharashtra, and I'm looking after an ICU and
Hello and good afternoon, everyone. I'm Dr. Srijana Dole. I'm the professor of pediatrics and head of department in pediatric department of the Head Hospitals. I'm looking forward to work with NMC. Thank you.
Hello, I am Dr. Siva Saisi. I'm an assistant professor in Patna Hospital. I look after an ICU.
Hello, namaste everyone. Good afternoon. I am Vivek Lamisane, Nepal Director of Operation, Ohio Medical University.
Namaste everyone, I am Ranjan Dugana, working for the Helping Pediatric and Helping World Music under LDS Charities. Thank you.
Good afternoon, everyone. My name is Dr. Brandon Tomlin. I'm a pediatrician in my first year of neonatology training at University of Utah.
And engineer.
And engineer by training prior to medical school.
My name is Dr. Allison Jeffries. I am a neonatologist at the University of Utah and also a member of the American Academy of Pediatrics. And this is my 10th term to DePaul. And I'm just grateful to be here and to meet you all and work with you all.
Hello everyone, I'm Shreya Boral and I'm a biomedical engineer at National University.
Hello everyone, namaste. I'm Sanjay Bahadur Singh. I'm a biomedical engineer at National Research Center. And yeah, this is our product, Nyano Nani.
My name is Mike Rajkesi and I'm an electronics engineer and also one of the key members of the product.
Namaste, everyone. My name is Ritesh Dev and I'm a mechanical engineer and I'm looking for all mechanical products over here. Thank you.
Namaste everyone, I'm Umesh Kirat and I'm a biomedical engineer and I'm looking after the biomedical department here as well as the products that we're developing.
Restaurant, people also can introduce themselves.
Yes, we have several members on Zoom. Maybe Dr. Poon, can you hear us now?
Trying to connect to the phone. Ask him to unmute. Yeah, yes. Unmute करने sir, unmute.
Hello.
Yes, sir, go on.
Yes. Okay. It's my turn to speak.
Yes, sir.
Okay. Everybody. Good morning from here. So I just told that I am in Liverpool, but I will be leaving soon to London for another meeting. So I will not be able to stay for long at this meeting. But I just would like to thank you all for attending this workshop, and I hope you will be able to discuss a lot about these projects that we are doing on baby warmer. And it's not only baby warmer, but there are several other biomedical projects we will be doing in future, and so we need to collaborate to make all those research in the field of biomedical possible. And I'm very glad that Bernard is there. I can see. Yeah, okay, sorry. Yeah. And the team from Ohio. So you are very much welcome to the Innovation Center, and I'm very happy that you are there. But I'm sorry I'm here. I will not be. I have not been able to meet you physically there, but we hope to see you in July when I will visit Ohio, New Med as well. So, and I just talked to Damodar, and he told me that he is a little bit sick, and so he's sleeping, and so that I just let him sleep. And but Bernard, I hope you will be able to, give your wisdom to our people there, and also to our Nepalese doctors from different hospitals. Dr. Damodar told me that, so you will be also there. So we need your help so much to move forward, and and uh, and I would like to thank you for your presence. Thank you.
Thank you.
Yeah, I will be listening you, but I will be traveling in about I am leaving from here in about 15 minutes, and so will be on my way to London. Thank you.
Thank you. I think we have three more team members who would like to introduce to the team. Dinesh, could you say a few words?
Hello, everyone. Hello, doctors, and hello, everyone. Welcome to Nepal's National Innovation Center. My name is Dinesh Bhuju. By training, I'm an ecologist, and I'm a board member of National Innovation Center. And thank you all for joining us. Thank you all for your support. And I'm excited to listen to you on this project. Please continue.
Thank you. Mr. Sanjay Paudel. Or Sonu.
Hello everyone, I'm Sonu Dakal, currently final year medical student from Nepalese Army Institute of Health Science. I'm very happy to be here and looking forward to learn more. Thank you.
Thank you.
Hello everyone. Can you hear me?
Yeah. We can hear you. We can hear you.
Can you hear me?
Yeah. We can hear you.
Hello everyone. This is Ms. Sanjay Paudel. Yeah, I am the digital health lead at National Innovation Center. So basically, we are building the electronic health record system and health application. So we support government institutions and community health institutions where they can leverage the power of digital health in order to carry out the quality of care. Recently, we completed 5 different implementations in the government hospitals, and one of the aged home care nearby the Kathmandu. So
Namaste. I'm Dr. Balbana Padeswin and consultant pediatrician at Maternity Hospital.
Oh, wonderful. Namaste. Lastly, just a few words about how this all came into existence. So I have 2 lives or 2 jobs. I'm a professor of pediatrics, and was practicing for more than 2 decades. But I always had an interest in making things better. And so as my career progressed in pediatrics, my research focus was on health systems and improving health systems. And that's how I got to understand that the only way of sustainable improvement in the health system can be achieved through innovation. But I also came to know that it's not the doctors usually who can improve the health system, because we are busy with practice, we are busy in taking care of people. So we need to form a much bigger team around us to improve health system. And so there is recently an article that my wife, Dr. Chatkins, forwarded to me from Forbes magazine that says engineers are the unsung heroes of global health. So what innovation really means is that we step out of our comfortable world of medicine that we acquire knowledge in textbook and really think in a much broader sense about innovation. So where collaboration with engineers is not optional. They are more important than we are, but they can't work without us because we know what the patient needs. So what the National Innovation Center does is create an infrastructure that brings clinicians, engineers, and people who are in leadership, who manage health systems together to decide about priorities and then develop a solution. So thank you so much for attending today. I think the infant warmer is what brings us all together, but what unites us is much bigger, right? We all want to improve the system. So my second job as I progressed through my career was I ended up leading the Center for Medical Innovation at the University of Quito. And I learned so much about biomedical innovation and steps required, but that's not my passion. My passion is serving places like Nepal. And now I'm in a very fortunate position at the University of Ohio, where I've been given the task to say, go work with the best people in Nepal and develop a biomedical economy through innovation. And so that's when I got to know Dr. Poon. We immediately connected because we speak the same language. So the agenda today really consists of 3 topics that I would like you all of your guidance on, all your issues. The first topic is to really understand the clinical application of baby warmer in Nepal. In the US, there's so many resources. A baby warmer in the US, the cheapest one you can find is $30,000. It's ridiculous. And there's no upper limit. What is actually an application that would be suitable for Nepal, and how would it be used? So let's sort of define the need and the people who are going to use it. And that's what we call in entrepreneurship terms. We do market analysis. So I need to get your input, your opinion about who will actually need that thing, who will use it. The second thing we're going to talk about is design specifications. So a baby warmer can do many things, right? It could be a phototherapy unit, it could be many things at the same time, but it doesn't need to be all of things. So we need to achieve consensus among us all what a baby warmer unit should look like so it's feasible in Nepal. Our input is useless, right? Because we come from a different country with a different culture. It's a Nepali project, and all of your input will help design this right thing. The third part we need to talk about is, in order to have a product that can become that you can use in a clinical setting, we need to make sure it meets standards. And so there's again 2 types of standards. There is the engineering standards, and then there is the clinical standards. So for engineering standards, we have our team compiling what the standards are. But for clinical standards, we try to do a literature review about Nepal and hypothermia management. There is national guidelines, but our product needs to be validated towards those guidelines so we can confidently say it's a good product. We need to compare it to other products that we currently use and make sure it performs as well. So these are the three things I would like to accomplish. So for the first topic for the clinical application in Nepal, I would like for each of you, or we can even have a real discussion. We don't need to take turns, but a real discussion where we just take notes. And I hope you don't mind. I turn my recording machine on because I need to listen to this again afterwards. Like your opinion. We're all sitting here because I think we all see value in a new infant form. Like a couple. What's your experience? Why is this interesting?
Interesting. We are using all the new second of our attended in our unit is under integrated format. Even preterm robot-weight babies who needs actually incubator care. But the incubator care in our setup is very costly, and we found that those babies who are under incubator gets infection very easily, maybe because of our standard of feeding standards or standards. So we prefer to treat those babies who are late robot weight are also under open tests. So dating format is very important to NICU and even special and we have used this Nyano Nani. We have used that. I have experience of using Nyano Nani. And again, I can point out what is the thing that needs to be improved in that. Because we found that the baby was put under the Nyano Nani. Extremities usually gets cold because we thought that is because of that major radiation is not. It's like radius is not that.
It's not even.
Even. So center is okay, but the extremities, because the heat that doesn't directly come. Maybe
No, it makes sense. Yeah.
So that needs to be improvised. In that case, and it has got two sensors. One is sensor, air sensor, and another is skin sensor. And most of the time, our staffs, sisters, they usually get confused with those two sensors because in other warmer we use only one sensor, skin sensor only. So that sometimes that air sensor they are attached to the skin. So in that case, that it doesn't work. And another thing is that the barrier is something the warmer. That is even after using for 2 days that got broken. Maybe that quality because in our hospital there are so many staffs. The handling might be very rough. So that might be the cause, but the material is not that tough. So it's okay if we make that of steel or iron, but that plastic material is not that. So otherwise the warmer is okay. That's fantastic. It's working till now. Initially we had some problem of calibration, but after calibrating, it's working. But
you mean calibrating because like the babies would get too hot or
too cold?
Too cold.
Most of the
I
time.
see.
It was not even. Sometimes it gets it produces sound and it's showing 38 degree, but the baby is not.
I see.
So I don't know what was the problem, but I think we used the calibration.
Calibrate.
After live calibrating, I don't know what they did, but it's worked.
They fixed it. Okay, all right. That's good. Dr. Shiva, I think you use them too in Parkland Hospital, right?
No, not yet. I haven't the proper to use that.
Does anyone else use them? Not this row. Okay, interesting. So, Dr. Shiva, let me ask you. we're trying to decide about indications for use. What are the Nepal indications? When do you decide a baby needs to go in a baby warmer? And would the indications be same in a university hospital, in a district hospital, in a primary health center, or in a birthing center, or would that be different?
I think the indications are different in different centers, purely because of the availability of the warmer centers.
Let's assume every center has it.
If every center
Yeah.
has warmer. If every center has warmer, I think nationwide we should have the same criteria. That would help, babies all over the world get the same standard of care. That would be fantastic if we could do that. But at the moment, realistically, very few centers have enough warmers to put all the babies to the criteria. We are lucky enough to have warmers when we need it, and all babies who are very sick babies who are like CPAP, even term babies put under the warmer. So all babies who need continuous monitoring are informed and have I'm talking about the term baby, what it does. And we have babies all the extremely low birth weight and very good birth weight. So basically, under 1500 grams, the ultimate warmer.
So, Shana, when you look at Hill Hospital, how do you decide when a baby goes in the womb? Is it like less than 1500 grams, less than 2000 grams, or?
Because we have radiant water only in our NICU, not in the neonatal wards or in the birthing center with mother. So those who are less than 1.5 kg, so they will be put under radiant water. Although preterm will be less than 24 weeks, they will be in the radiant water. And then term baby only they are septic. So they will go into hypothermia like that. So on those space we put. Otherwise, term baby and post-term like birth asphyxia we usually do. And then normal baby just come for some like other thing we put on the. We don't do radiant warmer all the time. Sometimes just put in on the bed, but we offer radiant warmer. But less than 1.4 kg and then less than 34 weeks septic child, they will be in radiant warmer.
The reason why I'm asking so many questions is, let's assume we make many baby warmers, right? The people from district hospital and some people from PhD even on the they're not near neonatologists. What we don't want is to replace KMC care with a warmer. Because KMC care works, cheap and disinfectant. So the outputs from our group today that I would like to achieve is consensus on what to do together. And we may not have a final document, but you guys take notes, right? We'll create a document. And this needs to be published because this needs to be shared knowledge within Nepal criteria or indications for an infant in a form. So you gave a lot of hints, like less than 34 weeks. What or do you also use birth weight as a criteria? Let us 1500.
Once the babies are 1500, we need to take them out of the baby warmer or like to switch it off and try that in temperature wrap. So trying to get them ready to open because by 1800 grams is enough. So we think that it's necessary to sort of try them in the temperature as well.
What do you think?
So as far as what we are using is, we are those who will require intensive care, we are taking the baby to the rated one.
Okay.
We don't think about other thing, but as the baby requiring intensive care or any further movement to put the baby in rated one, and we are fortunate to have a good ICU setup where we are enough. But those who require intensive care from the side.
Okay. Yeah.
In our hospital, we have 40 bedded NICU, not the NICU, neonatal units. So 10 bedded NICU where baby needs ventilator care, and 20 bedded special care units. And we have only 2 staffs at a time. So if you don't put baby under radiant warmer, baby might get because the staffs are very less in number. Sometimes there's only 1 staff for 20 baby, 25 babies. So she cannot monitor every time. So in that case, that's why we prefer those baby who needs admission in SNCU or NICU. NICU obviously everyone is monitored under the trauma, but even in SNCU, those babies are sick. Sometimes somehow they need IV antibiotic or any monitoring. So those babies are plus to having regular temperature and then because of the scarcity of the nursing staff. So after if babies are preterm low birth weight, in that case under radiant warmer intermittently would be his mother or intermittent KMC, and once baby is stable, we shift to KMC ward. And other babies, term babies or those babies who are stable cannot maintain temperature even without radiant warmer, they are shifted to mother side. So in postnatal ward, we don't use radiant warmer, babies with mother, and KMC we don't use. But in case of NICU and SNCU, we use them. And even the government policy is that for SNCU, establishment of SNCU, they should have radiant warmer.
So here's an interesting question that I also want to ask. So Dr. Ellison did a literature review about like the prevalence of hypothermia in the Baltimore. Comment what you found.
Yeah, I also have two other questions.
Oh, sorry.
I just want to make sure I understand. So for low birth weight and ELBW, BLBW babies, is start in the warmer, and when they're stable, then you shift to KMC care, and that's a step closer to being ready for discharge. That's theoretical. That's this one. And then the second question is, what I heard you say is that when babies are in the infant warmer, it seems like a signal to the staff that this baby is sick and is in need of care at NICU or SNCU. And are the monitors also like they come with the radiant warmer? So the baby is on the radiant warmer, they also have monitors with that. And so are there other beds or other places where you would put the baby that's not a radiant warmer where you would also have monitors, or only warmers? Only warmers.
In our hospital, we do use monitors in those preterm babies who are out of the warmer, but if they are still in the neonatal nursery, we use the monitor. But I don't think that it does that.
Okay.
But as you rightly pointed out, if the baby is in the radiant warmer with a monitor, that is an indication that the baby is prioritized over others and it's more safe.
It says
We have a limited number of warmers, so we have to kind of triage who is more sick, and those are safe going to the monitor with the radiant warmer.
So this makes sense to me. I'm also not an engineer by training. My interest is in implementation and how the products and how things are used in clinical care, the practice of any new device, new monitor, how that shifts. And the human component is important. So like nurse sees the warmer, sees the monitor, this baby needs attention. And then to go back to your.
So the question was, how common is hypothermia in the fall? And I think my hypothesis would be Nepal is not very homogeneous as a country, right? There's urban, rural, high altitude, low altitude, and
this is where there was a need, there was a message that was sent to the NIC to say we need infant warmers. But if you look in the literature, do a literature search to discover about hypothermia in Nepal, there's only 3 studies that really look at it, and they're old. This is from 2010, 2011. And one study looked at hypothermia at 28 days from whole birth. And so temperatures were measured at home at 28 days. That was one. There was one other study that was at Patton Hospital. And that one was also.
Were you involved in that study?
You're nodding. I was wondering as you were reading, like, I wonder if we'll meet some of the people who wrote it. And then there was another one that looked at Patton Hospital comparing death outcomes for babies that are cold, which we know there's well documented literature that hypothermia increases the risk of death, and the more severe sort of stratifies the risk. So mild hypothermia, which is 35, 36 degrees, moderate 34 to 35 degrees, and then less than 34 degrees. And then the colder you are, the higher risk you are for death. So we know it's a problem, but the literature that in Nepal that looks at how to address that and how to solve that problem and what equipment, what implementation, how to help, that's not there. And we also know that it's very undermeasured. So there's only three papers, and they're all more than 10 years old now, for really the prevalence of hypothermia in urban centers, which is easier to measure, obviously, with your busy big hospitals. And then what happens out in the remote areas, which is what we are most familiar with in our.
But what were the outcomes of these studies?
The individual high risk for death.
No, but I mean, like, what was the rate of, like, at 28 days for hypothermia? Like
50%.
That's the key point, right? The key point is if you measure, you find it. So there is actually, but what we took home from that literature review is there's probably a lot more infants who need it, right? But we don't know if in the well baby section, there's probably a lot of infants who need it. So because we don't measure it, we don't know.
Can I ask if that's the previous study on term babies or preterm babies, the study that you're putting?
Oh, it didn't specify. So there were babies that were at home at 28 days. So you can probably at least close to term, late preterm, and term babies. Yeah, and that is not, it's not involving the yeah. They also went in, they also went in and talked about some of the practices, the standards of practice for thermoregulation just in general, like KMC care. Is the baby dry right away before you cut the cord? Is the baby kept warm with mom, and the risk factors that go into hypothermia? And those really talked about education of the mother, education of the staff. Was the birth attended by an SBA trained provider? Then these babies had less hypothermia and they did well, as you would expect, or better as you would expect. But then really what happens after that is we don't know.
And the other study showed that those babies who were hypothermic, right, had an 80% higher death rate. Not surprising. But the take-home point from this is we actually don't know how many people and how many hospitals in Nepal would really need the warmer. Because we all come from very high level centers of care. So we have our criteria well defined. Actually, you have your protocols and you know which baby goes in, which baby doesn't go in. But this, so what I was hoping we can achieve today is an agreement that we need to generate more data to actually really know. So what we would like to propose as a group effort, what this group could do or should do is we should identify hospitals in urban, rural, very rural settings, like a cross-sectional study that we think is representative of Nepal, and measure actually infant temperatures of those who are not in the warmer. It would be really interesting to know, so what is their temperature 6 hours after birth? We may find, well, that's not a problem, right? That's great. But we also may find maybe 30% of them are. I just want to throw it out to the group to see if you would embrace such a study, which would be, I don't think it would be very difficult to do, but it would require coordination and sort of leadership within Nepal. But I think as policy makers, you would have a lot of information to go to the government and say, this is a big deal. We need to put resources. Well, I think we are the right group of people to lead the study, but we need to collaborate with different hospitals. So here is the question back to the NSC team, right? So you supplied infant warmers to 31 places already.
41.
41. So they reached out to NSC because they thought they had a problem, right? So can we ask those 41 centers to be our partners? I still think there's value in involving each of your institutions as well. Because I think we ought to look at all, it's like for the maternity hospital, I think there would be value to look at those infants who are now in KMC care with the mother. Maybe that's fine, right? They don't have a problem. But I think it would be worth a look. So I would love to design a study that allows us to determine the prevalence of hypothermia in a variety of settings. And
Are we going to assess hypothermia in those babies who are admitted in SNCU or those babies who are with mother?
those babies who are with mother.
So if we find
Oh, I don't know. What do you think? Yeah, how would you suggest the best study design?
So collaboration is always PhD level to have two levels. We are not a formal PhD, I think after delivering they are going to the mother side or they are going to home. So we are not able to visit.
if suppose if we find that babies who are with mother are having like suppose 30% of the babies are having, are we going to provide latent warmer to them because they don't have any symptoms? Provided those are the babies who are going to discharge after the birth.
That's a question for the neonatologist. I'm not a neonatologist. I think that requires consensus among a group. Right?
ICU, maybe in the intermediate group, they can transfer. Yeah. Yeah. But I think this is really the good study because we may be underdiagnosed like.
That's my hypothesis. We do work in very remote areas like Simicot and Humboldt, right? That hospital, ice cold, even in summer, the wall is so cold in there. And if you're a newborn, it can't be good for you, you know? So if you agree as a group, then we would love to sort of draft a study protocol and for assessment, and then really go and look at some of our primary health centers, but also look at your own hospitals and see where's the difference, right? And I think we could all be much better informed about priorities of need.
So actually, we've been sending out our team members regularly to take some feedback from the places that we installed our warmers. But currently, we're just taking feedback regarding the equipment only. So, but since we're sending out people time and again, I think if we had a structured questionnaire or a certain protocol that needs to be followed, I think we will be able to extract those data from all.
These 41 cases, they are mostly
Yeah, we have in urban areas as well, but almost more than 70%.
Can you share the full list with the group after our meeting? That would be really helpful.
And how long has this been out in the field?
We 2020, 21 until now.
2.5 years.
2.5 years. It got a bit slow during the COVID time, but in 2020 we had, I think, 20 installations, and even in 2021 other than 20 installations.
The majority of our installations are at small primary healthcare centers where they have working facilities.
So, like, just to give a small perspective, like the bank who, like Sir said, was helping us financially. So what they do is, like, they have certain funds on their CSR, and they do a small assessment and they say, okay, we have a device which treats and which is being used in birthing centers. And what they do is like they say, if you want any type of baby warmers, then send us a request. And in the request, you clearly write like how much flow you have, how many deliveries you have, and how many existing warmers do you have. And the proposals which are passed means like the proposals which are accepted, they don't even have one warmer, and they have been like treating babies, like they have been delivering babies. I'm not sure about the number, but I think on a year, I think 200 to 300 deliveries. So I think that's the need there. So I think 60-70% of them are of the total warmers out of the 41 are in those areas, because the majority of the budget comes directly from the government. And the rest is like say like a partner hospital facility here, like we are like collaborate and we generate funds and then we like.
So one of the reasons why I invited Mr. Deepak and Mr. Ranjan today is they are experts in implementing health programs in some of the most remote areas of Nepal. And Mr. Ranjan, he has been the Nepal lead for a neonatal resuscitation program that implements helping babies breathe. I think you know probably many members. And in the next version of newborn surveillance for Nepal, hypothermia management is going to be part of it. And so as we sort of train people on hypothermia management, I always find it funny, like it's a classic story in India. Everybody's trained in NRP and neonatal resuscitation as like a plaque here, but you go to the delivery room, there's not even a bag and mask, right? So they are trained, but there's not the necessary equipment to perform the task. And so as we go about our training, I would also like to address the equipment issue. Like equipment and skill, they're two sides of the same coin. And so, Ranjan, do you want to maybe comment really briefly about like hypothermia and how does it fit into the national effort for?
Actually, currently, just focusing on the resuscitation that is totally missing in our country. Just we took the drive the baby and just warm the baby, and just that part. In the case of hypothermia, we are more focused on the newborn resuscitation.
I think what the government will also some part is included, because we deliver the baby and one mother's and dry immediately, and then the baby and
that part is included, but the measurement of the temperature,
yeah,
that part is totally missing.
So I think in our study we need to measure temperature at one hour of life. And then we can follow at 6 hours of discharge. Yeah.
And I think you're raising a really good point. The training, the teaching is in hypothermia prevention. Try to baby skin to skincare. You don't weigh or bathe the baby within the first 6 to 24 hours if they don't need. And it would be interesting also to know, like, it's done in your centers where you're highly trained and your staff is highly trained, what the thermal regulation practices really are. When we kind of get out and see, because most babies don't need the warmer, right? KMC care is free, it works, but we don't actually know how often it's practiced. And so I think that would be part of the cross-sectional study too, to see what the practices are with thermal regulation in the first place. Because most babies, after 1 hour of KMC care, their temperature is good.
I can share my experience.
Yes, please. I was wondering.
I was involved in quality improvement project in our hospital. Yeah. In that case, in that project, but that is let's try for hypothermia management, which is the temperature of the baby at the time of transfer from the labor ward. So initially we found with just pre interventions, we found that 55% of the babies are hypothermia at 1 hour of life. Because we try to find out what was the cause, because we trained everyone who are estimated with resuscitation procedure. But we found that instead of putting baby in skin to skin contact, they used to take the baby for weighing the baby and putting the that codex in the part here. Yeah, and after around 45 minutes, 50 minutes, after that only they put the baby for skin like that. That's why the process was like they have made. Skin to skin immediately after birth, and only after 1 hour after breastfeeding they take out the baby from our skin, and that drastically improves the temperature. It was very difficult because we don't have.
Delivery after delivery after delivery, right? So I think Do you think there is a
we come back here, I have 5 questions for you that I would like to discuss as a group, as you see that device. The second thing I want you to keep in mind is a baby warmer is static. So there's a baby and there's a hospital.
what do you do if you shift the baby? Like the baby is born in a PHC, you decide the baby is small. You need to refer.
Jadi bisa teman-teman